Yeah.
probably don't necessarily do that, but you wanna make sure you know that. For the femur, you also wanna have the receptor portrait. You wanna, again, go with the long axis of the body that you're so flip it portrait, and I'm gonna keep it this way for both views. So once I have it in my bucky and I'm lined up, I'm not gonna touch it anymore. So now I'm remembering the center to my table, and I'm gonna align here. Make sure I'm at 40. Alright, so now anything I have to do from this point, I'm gonna move my patient, okay? Not gonna touch here or there. Alright, so for our distal, let's start off there. You can really start off anywhere you want, either proximal, distal. I just always prefer to start off with the distal, so I'm gonna move my patient leg a little bit more in the center. Just do that slight rotation. Remember, you're only going 5. And basically what you do is you just come down to make sure that your collimation is including the knee joint, because we have to have both joints on our image. So I make sure that make sure my knee joint's included on there. I'm going to bring in my collimation this way, and then I will put my marker. So which marker am I going to be using?
Right.
Correct. So I'll just put my marker right here where it's out of the anatomy, but I see it in the light field, or you can put it on the receptor too, however you prefer. So that would be my AP
Distal.
for distal. And then a trick that you can do just to make sure that you have the entire leg covered, which you are, because you're using such a large receptor. There's no way you won't get it covered. But if you want, you can put a piece of tape where the top of your collimation ends, and now we want to get the proximal portion of the femur. So I'm going to slide her down. I'm coming your way. So as long as I make sure that that tape is well within my collimation, I know that I have the entire shaft covered. I'm not going to be missing any portion of the shaft from my first leg. Here is where your central ray is going to be talking about your ASIS. So you want to feel that to use as a landmark. But typically, we just go up, make sure we've got that tape covering, including, so we make sure we're not missing any anatomy. And then same thing, you don't have to really do any adjustments with the collimation because you've already brought it in side to side. You want to get as much of the bone as possible to make sure you have that overlap. My marker is still fine where it is. I'm just going to rotate her in a little bit more because we want that 15 to 20 degrees now that we're on the proximal portion of the femur. So that would be my AP femur. If I wanted to shield, I technically could just put a shield here. Just be careful that it doesn't overlap in this region to block out your proximal femur, like the head and the acetabulum and that type of stuff.
Okay.
When we're doing the hip, it's exactly the same thing, except we're not doing a proximal and distal. We're only staying up here in the proximal region. So what I would do is I'm going to bring in my collimation. Typically for a hip, you can actually use a 10 by 12 receptor if they have a smaller one. And this is where you can use that little crease trick. Remember I told you guys about bringing up the patient's leg. So Miss Wallace, bend your knee. So I see where her crease is right here. So I want to keep that in mind, and I'm going to center right in that fold or crease. So right there, because that's going to put me right where the femoral head is, the neck region. Relax your leg. I'm going to have her do that 15 to 20 degree rotation. I could take this off because we don't have to overlap with the tape anymore, but I want to make sure that I bring my marker up. So that's included. So that would be my AP hip. And then for my lateral, I'm going to frog leg her. So I'll ask the patient to bend your leg and relax it. And this would be my lateral or frog leg. And I don't have to change any of my centering because all I'm doing is changing the position. She's not moving on the table. I'm just literally manipulating her leg. Sometimes it might be comfortable to put a sponge underneath the patient here, depending on what's going on with them, so you can do that as well. But you need to abduct it 45 degrees. So questions? All right, Miss Wallace, you can relax. So what do we have left?
Okay.
So we'll do the pelvis at the very end, but we're still missing something we haven't gone over.
The cross table.
So, both of those. So we got to do the lateral femur, right? Because we did the AP lateral hip, but we didn't do the lateral femur. So we got to do the lateral femur, and then I'll show you guys the cross table lateral for your trauma patients. All right? And that one is a mandatory comp that you guys have to do. Have you guys started comping on any hip pelvis stuff since we reviewed it?
Yes.
Doctor? No?
I have.
Okay. So the cross table hip, which is also known as the Danielus Miller, that's for your trauma patients that aren't able, you don't want to manipulate them, okay? Either because they can't move because of the pain. You might suspect that there's an injury because remember we talked about the leg being shortened and externally rotated. That's a classic sign that there's a fracture in the proximal femoral region. And usually when patients come in with like hip pain and things like that, it's always, pelvis is always included with the hip series. So usually we do that first just to get a general overview of what's going on, and we pretty much will usually see on there if there's a fracture, and then we know, okay, well, we're not going to abduct this patient's leg. So that's where the cross table lateral comes into play, because we're basically manipulating the x-ray tube to do that lateral projection as opposed to the patient doing the position. It is a required mandatory comp. You're not going to see it a lot because the techs don't like to do it because it's a little bit more involved and cumbersome. So sometimes the students will ask to do it. But usually the technologists or the staff in the clinical sites will be more willing to do it if you ask to do it on a walkie-talkie patient because it's easier, you know. You're not going to have the challenges and the patient's not going to be as in, you know, pain and things like that. So some of our senior students still have not done it. We can simulate it if it comes down to that at the
What
very
you mean
end.
by simulation? I see that on the book.
So that's basically when you are doing a competency, but it's not a real it's not a patient that has an order for it.
Okay.
So you can do them in the clinical sites and like ask another tech to be your patient, and you would just go through the motions. You would do everything except to expose.
Okay.
So you could do it in the clinical sites, or we can do it here, and normally we'll leave that for the very end because we want you doing as much comps in the clinical sites as possible, and there's only so many simulations you can do. You can't do like 20 simulations. So we leave it for the last resort, and usually we'll start doing it with senior students that fall into that category towards like March, like around this time, like March, April, before they graduate. So some of our students, senior students, have had the need to do that, and they've been doing it in the clinical sites. For those that may not have time, because some of the clinical sites are busy and they may not want them to do simulations, or they may not have downtime to where they can do it, we're going to start having them come in campus to do it. But it shouldn't be a lot. You shouldn't need to do more than 6 simulations. You really should be getting the bulk of your competencies in clinic. So that's what it means when you see that. All right, so let's do our lateral femur. So same thing, we're gonna do the proximal and distal. So I'm gonna do my proximal since I'm up here. So you wanna make sure when you're going through these exams, make sure you're doing things that make sense. If you've got an order for a pelvis, hip, and femur, which sometimes you might, you know, do your proximal femur when you're doing your hip. Instead of going up and down on the patient. So do things that make sense. If you already have the patient in a lateral for the femur, okay, make some minor adjustments and do your frog leg or your lateral hip while they're in that same position. So notice I haven't touched my receptor at all because I don't need to. So we're just gonna come in again where that crease is, and I'm gonna open up my collimation this way because again, I wanna get as much length of the femur bone as possible. And when we're doing the lateral view of the femur, we like to turn the tube to go with the angle of the bone that we're examining. I could put my little marker here with my tape just to make sure I cross-reference and get the full shaft and I'm not missing anything.
Will that tape like show up in the radiograph?
It would have to be like a thick piece, like it's wrapped on top of it. Itself in order for it to show up, just like one piece like that. Well, I put my marker here, and I am gonna do my exposure. So this will be my proximal lateral femur, and then I'm just gonna slide on down to get my knee joint. Just watch, relax your leg a little bit. So I wanna feel for the knee. I need to come down a little bit more. So now I've got my collimation covering my knee. I know I've got my tape included in my light field, so I know I'm gonna get the full thing. I'm just gonna bring my marker down a little bit to make sure that's included. So AP lateral hip, AP lateral femur. Pretty easy, right?
Mhm.
All right. Now, if this was a real patient, I would have had Miss Wallace remove her belt and probably her pants because of the zipper. Like, I don't want to take any chances with that coming out, because then you have a repeat.
Mhm.
So just be careful with what the patient has on. All right, so pelvis. How are we positioning for the pelvis?
AP.
So we just got that one AP. We did talk about those specialty views, the inlet and outlet. I don't think I put that on your test, huh?
I believe.
I feel like it was.
Yeah, I believe like
Yeah.
one.
I don't remember.
Yeah.
So we've got those specialty views, but those are not routine part of the pelvis. Usually if you have an order for pelvis, it's just gonna be one AP and that's it. But when you have the hip, usually they do automatically include a pelvis with that. So really when you get an order for a hip, depending on where you are and what the protocol is, you can really get two comps out of it. You can use the pelvis view for the pelvis and then the AP lateral for the hip. Alright? So how are we positioning the patient?
Centered on the table.
Mid sagittal plane. Yeah, their feet touching,
Rotated in.
touching each other, like, yeah.
Right. So we want their toes touching.
Mhm.
That's gonna assist with that 15 to 20 degree internal rotation. But we typically will do that last, because if you do that from the beginning and then you go to position your patient, they're gonna get tired of touching their toes, and they're gonna automatically start to relax. So we usually do that at the end. For the pelvis, it's really important that you make sure that the patient is in the center of the table, because you wanna make sure you get the full width of the pelvis. You don't wanna clip the left or the right side, or anything like that. So you wanna make sure that they're in the center of the table. And then are we gonna leave our receptor portrait?
No, crosswise.
So we want landscaper crosswise. Because we want it going with the width of the pelvis. Alright, I'm just gonna double check, make sure it's lined up. It is. So now I just have to make adjustments with my patient. Alright? So the centering, the majority of the centering for all of these is gonna tell you to go halfway between the pubic symphysis and the ASIS, and then you kind of intersect the lines, come down an inch for the head, 2 inches for the neck. For the pelvis, we can do the same thing. We can basically go at the level of the ASIS and just make sure you're also in alignment with the mid-sagittal plane. So Ms. Watts, point to your ASIS for me. So that's her ASIS. So I'm gonna come down, and I'm already pretty much mid-sagittal. Okay, you can relax. So I'm good there. Now I just need to adjust my collimation. And I asked Ms. Wallace to point, but you can easily palpate that on the patient as well. I think Fred, I don't know where Fred is. I think he's in the classroom. I was just gonna point them out on Fred. But those are, those pretty prominent landmarks on the anterior region. So I'm gonna adjust my collimation. I wanna make sure I open it up wide to get the width of the pelvis.
Do you put the skin borders into, like, if it were like a hyperstenic patient, are you gonna like go all the way out just because it's maybe a little bit difficult to see?
Well, we would never exceed the biggest we would open it would be to the size of the receptor. We wouldn't exceed that, even though the patient's body habitus may exceed that size, because it's not gonna capture anything. So that's the largest that we would open it. And sometimes you may have those morbid obese patients that are exceeding that size, but you'll be surprised how their frame inside, like their bone structure, is usually not like the same of an average patient. The more times that you would have to do like multiple imaging to get all of the anatomy is like in an abdomen, because you're actually looking at the internal structures. But the pelvis will be like the same size.
So, like, how would you kind of determine where to stop your collimation, like crosswise, if they like are morbidly obese.
I would just try to get a mental picture of the size of the receptor
Mhm.
and just kind of collimate to how big I feel that is.
Mhm.
A lot of the equipment automatically collimates to the size of the receptor, so it does it for you. I don't know if you guys has worked with any equipment with that. So if you're doing like a 10 by 12, it's gonna automatically collimate to a 10 by 12, and it won't even allow you to open it past that. It'll just allow you to close it in. Same thing with the 14 by 17, but just try to get a mental visual of the sizing of the receptor if it doesn't have that automatic collimation feature.
Okay.
All right. Another thing that you can do, now that I have this out, another thing you can do is you can also use the top of the top of the receptor and put that like an inch above the iliac crest. Okay, so that's another positioning trick that you can do. Once you have it an inch above the iliac crest, you just center your x-ray tube to here and make sure you center your patient. So you could do that too. All right, so I'm midline. I'm at the level of the ASIS, which is more or less where I want to be, and I'm going to have the patient touch their toes. Is the last thing I would do. To do that internal rotation, I'll tell them to take a deep breath in, let it all out. As I'm walking away, make my exposure, and then I tell them to breathe. All of these images that we've talked about are on suspended expiration. You want your patient to hold your breath. That just helps to minimize any potential motion, especially when you're doing the pelvis, because now you've got more of the abdomen in there. So questions? Alright. Yes, cross
Well,
table
let's show
out.
them another, so that they don't have to palpate their patients.
Mhm.
So if my ASIS is right here, you have them bend versus you having to touch the
Mhm.
area. Okay. So y'all see where if they bend, just go up a little bit above that.
Okay.
You'll be fine.
And also, you might have older patients and they may not be able to do the frog leg or abduct 45 degrees. So you can oblique the patient and get the same effect. So if I'm doing the same right side, I would just have the patient turn a little bit to the right. And in a sense, I could get my lateral femur or my lateral hip if they can't actually move their leg away like Miss Wallace can. But even though that's a little trick, we would still not do that with our trauma patient that has a positive fracture or dislocation or anything like that, because in order to do that trick, you would have to roll them on the affected side. You don't want to do that. That's going to be real painful for them. So you would still have to come in and do the cross table lateral. Thank you, Emma. Which I'm going to show you guys now. So with the cross table lateral, I'm going to show you guys how to do it from a clinical and lab standpoint, but make sure that you have the centering, make sure you know the centering landmark for the cross table lateral from your textbook, because what I'm going to show you is not in the textbook, and you want to make sure that you're aware of how you're supposed to center, because basically with the cross table lateral, you want to make sure that you're in alignment with the receptor and the grid so you don't have grid cut off. A lot of students think that you're supposed to aim or be centered to the femoral neck, but that's not what your textbook's going to say. So someone look at the textbook and tell me what it says.
For which one, Doug?
For the, yeah, for the cross table lateral, for the Daniela Miller.
Rotate affected leg internally 15 degrees. Place IR in the crease above iliac crest and adjust so that it is parallel to the femoral neck and perpendicular to the CR.
Oh. Andrew, you see that little stand on the-
That's all it said.
the stand over there? Yes.
Okay.
What is that?
What if you get the opposite leg up? So the key.
I'm gonna tell you guys another way that you might see it worded.
Okay.
In opposition to that, because there's different positioning books out there.
Oh,
So
okay.
I want you guys to be familiar with another way it's worded, because this is how we're seeing it come up on the registry. It's not gonna give you the formal thing.
Okay.
So I'll probably email it to you guys.
Okay.
Alright, so for the cross table lateral, the x-ray tube is going to be on the opposite side of your affected leg. So in this scenario, what would be the affected leg?
The left.
Mm-hmm. So the left is the affected leg because my x-ray tube's on the opposite side. So I need to put my receptor on my patient's left side. And for this one, again, you can use a smaller receptor, because usually when we're doing this, it's for the hip. If you're doing it because they ordered a femur and the patient can't be manipulated for the lateral view of the femur, then you would obviously want to use a larger receptor. But you could use a 10 by 12 if there's one available. You also want to make sure you put that grid over here. All right, so remember last when we were doing our lab test with the decubitus, you want to make sure you put the grid on for your abdomen decubitus. Same thing, we're still examining a thick part of the body, so we want to make sure we have our grid slid on here, or you use a receptor that has a grid built in. So you want to put the receptor against the affected side, so in this case it's going to be the left. Sometimes your patient can help and you can ask them to hold it. If they can't hold it, we can just get a sandbag and put against here to hold it, or we can use the cassette holder to hold it. And there's also ones that kind of hook on the table too. So you've got a variety of options. For me, the easiest one is if the patient can hold it, I'll just have the patient hold it. You also want to make sure that the receptor is parallel to the surface of the x-ray tube. You don't want the receptor this way and then my x-ray tube is angled, because you're going to have grid cut off. Okay? So you got to angle it with the same angle of your the base of your x-ray tube. Do you guys understand that? All right. So you want to have everything set up. One of the last things you want to do is elevate the unaffected leg, and the reason why we're doing that is because we got to get it out of the way so you don't have two femurs or two hips on top of one another. So that would be one of the last things I do, because sometimes that's uncomfortable for the patient to do, or it might be a little bit painful for them to elevate the unaffected leg. So I want to get all of this set up in alignment, make sure my centering and everything is correct before I do that. So I'm just going to come back over here, and you see where my line is, right? So I got to make sure this line is in alignment with my receptor, or else I'm not going to get the image I want. So I'm going to bring this back down a little bit. So I'm aligned there. And also you want to watch your red centering line. Okay, you don't want to have this too high, because my affected leg is down here. So I got to bring that down some. So I'm going to bring that down some. And then you could check your SID if you want. You want to be close to 40, but sometimes it doesn't always allow you to get 40 depending on your room setup, because right now I'm really close to the table and I might actually hit it. So sometimes you might have to go a little further out than 40. But once you have pretty much everything aligned, I'm going to put my marker. So which one would I be putting there?
Left.
So I want to put my marker in the vicinity. I can collimate in, because look, I've got collimation on the wall. So I got to collimate in some, because you're just only concerned about the hip, remember? Best rep, hit the lights for me. And then we're going to start to elevate the unaffected leg out of the way so we can see our centering. So you want to be able to go in the crease, because basically you're aiming for that femoral neck again. All right? So I'm going to bring my centering point up a little bit, and then adjust this up a little bit, because I want to make sure I'm centered. I'll have my patient relax their leg down. Miss Wallace is raising her leg up so she can really show you guys where you're aiming. Your patient ain't going to do that. So But you can, they do have this holder where you can either have their foot or their leg rested there, so it's up out of the way. But most of your patients aren't gonna be that flexible, so you just work with the patient the best way you can. If they don't, and some of these holders are different. This is just the one we have here. They have all different varieties of them. Some of them have adjustable levels where it goes up and down. And if you can't find a holder, you can just turn over one of like the small trash can and just have them put their foot on that. Okay. Now, obviously, if it's full of trash, don't use it. But that's another option. Or sometimes what they'll do is they'll bring their leg over and have it actually rest on the X-ray tube too. So sometimes they'll do that too. But it just all depends on your patient comfort level. Because although this is the unaffected side, all those movements do kind of, have a play on the side that's injured. So that's your cross table. So you would just tell the patient to hold their breath, walk away, make your exposure. Now the tricky thing with this, because you saw how involved it's more involved, the tricky thing with this is just getting the correct techniques, because you do have to, typically you would increase your technical factors a little bit because you're a little further out usually, and you're having to penetrate more tissue going across this way. With the cross tables, you always are going to have a horizontal beam, so that's important to know. Usually you'll see that on test questions as well. But sometimes you have to do two because the first image may not penetrate enough and you'll have to go back and make adjustments to your technical factor, or you might be a little bit off with your centering and you may not get the full acetabulum region. You may have more shaft in there, so you got to come back and do some adjustments. So usually it's a little bit challenging to get it just right or correct the first time around. Sometimes there's usually involving a second image. Sometimes they'll also do these with the patient. Instead of in this format, they can do them with the patient up against the wall bucky. Like if they come in on a stretcher, and let's say they decide to do everything on a stretcher, they'll just put the affected side against the wall bucky, put the receptor in the wall bucky, and same thing. You'll have your horizontal X-ray beam with the X-ray tube, and then raise the unaffected leg. So you'll see it a variety of ways. You're not going to see it a lot because, like I said, they don't like to do it, but that's pretty much the setup of the Danielus motor. So any questions? All right, so that was everything. So let me turn this back around. I'll let you guys practice. I do have some lab sheets I'm going to give you guys for this stuff.